Good morning, good afternoon, and good evening, depending on wherever you're joining us from. My name is Lydia Wilson, and it is my distinct pleasure to welcome you to what I think is the 10th installment of this Community Building in Radiation Epidemiology and Dosimetry Research webinar, which is a series offered by the International Society of Radiation Epidemiology and Dosimetry. Just some quick housekeeping items before we get going. As always, please be sure to keep your mics muted through all of these talks. We will have 3 fabulous talks today, one right after the other, and then we'll have a combined question and answer session at the end. Please feel free to submit questions at any point during any of the talks using the chat function, which you should be able to find at the bottom of your screen. I'll be monitoring that, collecting questions, and then feeding them to our speakers at the end when we have our, our panel discussion. I do also want to mention that the Mentorship Initiative Network of ISoRED will be hosting a small group discussion after this webinar that is open to any trainees or early career researchers in this field who would like an opportunity for an extended discussion, small group setting with all of our speakers who will be joining us. We're super excited to have them. We will be sharing, it's going to be a separate meeting room, so we'll be sharing a link to that in the chat. So if you're interested, keep an eye out in the chat for a link to that meeting. It'll be just after this webinar finishes. So moving on to this webinar, the focus will be dosimetry for late effect studies for survivors treated in the pre-CT era of radiotherapy. And we're so excited to have 3 experts on this topic to guide us through. First, we'll have an introduction from Dr. Rebecca Howell, who is a tenured professor of radiation physics and the director of the MD Anderson Late Effects Group. Following Dr. Howell's introduction, we'll hear from Mr. Suman Shrestha and Ms. Constance Owens, who are both doctorate candidates at the MD Anderson UT Health Medical Physics Graduate Program. So without further ado, I'll let Dr. Howell take it away.
Okay, great. Thank you, Dr. Wilson, for that very nice introduction. I'm excited to be here today to tell you about the research that my group is doing, but more importantly, what the graduate students in our lab are doing. Come on. Okay, so I always like to start by introducing my team. I work with some of the most amazing people, medical physicists, dosimetrists, data coordinators, computational scientists, as well as the 2 students who will be speaking today. Also, just to the right of me is Susan Smith, who's an amazing scientist who's been on our team for a little over 30 years. And she's joined us today, so she can also join in the discussion at the end of the presentation. So some of the groups that we collaborate with are the Childhood Cancer Survivor Study, which is a cohort of 31 institutions treated for 8 different primary pediatric cancers, the St. Jude Lifetime Cohort, study cohort, the National Cancer Institute Radiation Epidemiology Branch, as well as investigators from the Princess Maxima Center. And with those collaborators, we worked on the decogulator study. So at a very high level, late effects seek to identify relationships between treatment exposures and late adverse effects. And when we say late, we mean greater than 5 years from the time of diagnosis in cancer survivors. In particular, for radiation epidemiology, studies that seek to establish dose response models between a region or organ of interest, the data that are really important are the dose to the organs and the outcomes in which they're observed. So for example, if you're looking at late cardiac disease, you would want to know the dose to the heart or substructures of the heart. But these data are often and most commonly not available in patients' historic radiation therapy records. So the cohorts that I mentioned were largely treated in several decades ago in the 2D era of treatment planning before it was common to use CT scanning. For example, the CCSS cohort was diagnosed between 1970 and 1999. And 1999 was really the beginning of the CT era. But even in the case when we do have CT scans, right, in radiation therapy, we don't scan the entire patient. So the CT only include the anatomy close to the treatment area. And often for patients who were treated in the early eras of CT planning, we only have hard copies available. which only includes selected views of the anatomy. So for example, if I'm doing a study on the heart and I have a cohort that has patients treated with, say, Hodgkin's lymphoma, as well as, say, medulloblastoma patients, for example, the brain treatments aren't going to have the heart in the CT scan, even if I had that information. So in all cases, for these types of cohorts, the organ doses must be reconstructed with the data that are available in the radiation therapy records. And so this is a lot of what my team does and has done for more than 3 decades, predating my involvement in the team even. So here's our general process. We start by abstracting the patient's radiotherapy records. And these actually come to us as PDFs now, but they can be anywhere from 5 pages to 250 pages. More data doesn't always mean more useful data, but our expert dosimetrists and physicists go through the records very carefully and extract particular information that's necessary to then reconstruct the treated fields. We use an in-house computational phantom, and we scale the phantom to the age at radiotherapy. And we're often asked, why don't we scale to the patient's height and weight? And these are data that are rarely available in a radiation therapy record. In particular, even if there is a height and weight available for children, they're growing very quickly. Their weight may change as they have chemotherapy if that happened before radiation therapy. And so the reliable data point that we always have and we use as a surrogate for BMI is age at time of radiotherapy. Once we've reconstructed them onto the phantom, we calculate dose to the organ or region of interest. We do a lot of quality assurance of the computed doses. And once that's done, we create an output file and documentation in what we call a data dictionary that we provide to our collaborators that explains what data they're receiving, how it was calculated, all the particulars of the output file. And I just kind of want to draw your attention to sort of the size of the cohorts, right? So we've done very small collaborations where we might reconstruct a sample of 10 patients to very large studies that have more than 10,000 patients. The CCSS, for example, has a little, approximately 13,800 individuals that were treated with radiation therapy, and then in total about 26,000. So there's a combination of patients treated with and without radiation therapy. So I wanted to give you an idea of what we do when we abstract a record, right? So this is a coding form that we use. It's very detailed, but we pull out the energy of treatment, the dates of treatment, the field orientations. We have a couple of sort of basic treatments that are very common in these cohorts, and so we have coding for that. The field borders, the ISO center, or the center of the treatment field, as well as information on organs of interest, prescribed dose. And we do this for each field. So if the patient received 10 different treatment fields, which is sometimes common with all of the boosts and cone downs that you might see. So you might have 10 pages per patient. So we record those. And then this is an example of what the data look like once we've reconstructed it on a computational phantom. So on the left is an image of a whole brain treatment, as well as in this little shape here is the boost treatment. And so on the right is a photograph showing you the patient on the treatment couch with their immobilization device, and then a tracing of what the field looked like. You can also see the spine field. This is a patient treated for medulloblastoma, and then a photograph. And on the right-hand side are 2 images of our computational phantom showing the reconstruction of the posterior spine field, the lateral brain field, as well as the lateral brain boost field. And then you can see some of the organs that we've reconstructed dose for. And I'm getting close to out of time, so I'm going to move past this. But I did want to highlight some of the dosimetry that we've done for the CCSS. So this is a list of organs for which we've calculated doses, and you may see in the literature. In most cases, we've calculated the mean dose, but for some organs, for example, the pancreas, we've calculated V20 and V30. We've also calculated substructure doses to the head, body, and tail. And then the heart is an organ that we've really spent a lot of time refining our methodology on, And that's what Suman Shrestha is going to speak to you about today. But I draw to your attention that our heart model now has 14 substructures. We've calculated dose volume measures such as B5 and B20, as well as the mean doses to those substructures. And recently, a graduate student in my lab, Ashish Gupta, worked on a project to enhance our computational phantom. So this image that I'm showing you is what our phantom has sort of looked like. It exists in code, but this is just a graphical representation. But it's actually, the organs are 3D grids of points. And so what Ashish did is that he converted it to DICOM format, allowing it to be used within a commercial treatment planning system. And so here on the right is screen captures of our phantom scaled to ages 1, 5, 10, 15, and adult. And you can see that the organs are actually 3D organs. So he converted those grids of points to volumes, and this is a rendering from the Race Station Treatment Planning system. And what's unique is that the phantoms can now be automatically scaled within the phantom within the treatment planning system using scripting that's a feature of the planning system. So that's a great lead into, now my students are going to tell you about the research that we've done. So really taking that phantom and making it a DICOM format is almost methodologically paradigm shifting for us. It's allowed a lot of new investigations, and that's what the graduate students are going to talk to you about. But I'm also the deputy director of the medical physics program at the UT Health Graduate School of Biomedical Sciences. So I'm putting our application deadline as well as a link to our graduate program. And then lastly, I did want to mention one other thing that my group does that might be of interest to some of the listeners here, is that we provide independent peer review of beam output for external beam radiation therapy. So we do megavoltage photon and electron, orthovoltage, cobalt-60. We also monitor blood banks around the world. But presently we monitor about 1,600 radiation therapy sites. This is a map of the locations of centers that we monitor. But importantly, I'm looking for a health physicist to join our team, and they would work closely with myself and Susan Smith. So if you're interested, please reach out to me. And with that, I will welcome Suman Shrestha to begin his presentation.
Thank you, Lydia and Dr. Howell, for the introduction. So today I'll update the group on our progress on the late cardiovascular disease front and what's on the horizon. So with improvement in cancer treatment and supportive care, we have about 500,000 childhood cancer survivors currently residing in the United States. And all of these individuals are likely going to develop some form of treatment-related long-term health issue. Late cardiac disease is one of the most common non-cancerous side effect, and it can actually be life-threatening or fatal. The risk of late cardiac disease tends to increase with dose and volume exposed to thoracic radiation therapy. And up until recently, around 2018, our entire understanding was based on mean heart dose and other such whole heart dose metrics. However, we all know heart is a complex organ with multiple substructures, and it's likely that these substructures respond to radiation in different manner. Recent studies from Hodgkin lymphoma survivors have actually demonstrated evidence of substructure-based dose response. The Nimwagen study showed a significant association between dose to the heart valve and valvular disease, whereas the Cutter study showed the association between ventricular dose and heart failure. Now, the evidence is actually not only limited to Dutch cohort. Recently, we've also seen such evidence within the CCSS cohort. Whole heart radiotherapy dose above 10 Gray was associated with an increased risk of coronary artery disease. Here, we're looking at a plot of cumulative incidence versus years based on mean heart dose. So a study of cumulative incidence of coronary artery disease showed that cumulative incidence increases significantly beyond 10 gray. As you can see, this is indicated by this yellow line corresponding to a radiotherapy exposure of 10 to 20 gray. And as the radiotherapy exposure or dose increases, the cumulative incidence of the disease also goes up. Now, the curves are essentially overlapping for the other three categories below 10 gray right here. Interestingly, on a substructural level, when we studied left anterior descending artery dose, we found that in addition to the dose response beyond 10 gray, again indicated by this yellow line, we observed significant risk in lower dose range categories as well, from 5 to 10 gray, indicated by this green line here. We observed similar results while studying the right coronary artery dose response, again indicated by this green line corresponding to a radiotherapy exposure of 5 to 10 gray. Now, so we have multiple studies that have demonstrated distinct cardiac substructure radiosensitivities. And our modern radiotherapy technique have the ability to deliver highly conformal dose distribution optimized to kind of reduce radiotherapy exposure to these radiosensitive substructures. But routine use of substructure dose constraints will not be common practice until we actually have validated risk prediction models. So the objective of my doctoral project was to develop and validate personalized cardiovascular disease risk prediction model that actually incorporates cardiac substructure doses. We divided the work into 3 steps. First was to develop a new cardiac model with the ability to complete substructure level dosimetry. Second was to update the dosimetry for the cohorts of interest and then study the impact of using this new cardiac model. And third and final step was to use the new dosimetry data, identify the most influential predictors, and then develop and validate risk prediction model. As of now, we're done with M1 and 2, and we're currently focused on M3. To develop the new cardiac model, we actually combined the 8 scalable capability of our computational phantom with the anatomical accuracy of the UF-NCI phantoms. So this slide basically summarizes the entire process. We first co-registered our phantoms, then extracted all the relevant contours for our study, then converted the data to spherical polar coordinate system for analysis, and then accounted for inherent differences between the 2 phantoms using only radial deformation. This actually helped us maintain substructure shape integrity. And generally in medical imaging and dosimetry, we work on a voxel or a pixel level. A pixel will be a 2D space on an image slice, whereas a voxel would be a 3D volume. Here you can see heart represented as a collection of cubes. Now, and you can actually do dose calculation for each one of these voxels or each one of these small volumes. As Dr. Howell previously mentioned, our in-house dose calculation system is not voxel-based, but point-based. So we have to convert the whole heart into collection of points that represents that particular organ. So to do that, we select a slice, and then within that slice, our code detects the organ boundary, fills that boundary with 2D grid of points in 1 millimeter resolution along X and Y axis or both axes. And then we repeat the whole process as we loop through different slices at 1 millimeter resolution. So in this manner, we convert a region of interest or an organ into 3D grid of points representing that particular organ. With this particular method, we developed multiple different models, and all of these models had a scalable capability. So the organs grew in all 3 directions non-uniformly based on a validated model that was published in Gupta et al. And all of the models had a scalable capability. We then chose the best model based on anatomical and dosimetrical validation. This is just an illustration of heart and substructure in 3D space as a uniform grid of points. The development, anatomical, and dosimetrical validation are detailed in our 2020 publication. We're very thankful for both the collaborators as well as reviewers. Their suggestions were instrumental in improving this study and the quality of the work. If you have any additional interest, I'll direct you to this manuscript. Now, since we developed a new cardiac model, we must study its impact. And then our cohort of choice for this was CCSS with about 25,000 survivors, and about 12,000 of them actually had received radiation therapy during the course of their treatment. So on the right, you can see a scatter plot of the new dose estimate using the new heart versus the old dose estimate using the old heart. And this clearly shows that the overwhelming majority of data points lies below the equality reference line, which basically says or shows that the dose estimates based on new heart are generally lower than dose estimate based on old heart. We further explored the data based on the 8 different primary cancer diagnoses of the survivors. Now, while the changes in dose for each one of these survivors depends on their respective disease, types of fields, prescribed dose, blockings, overall, we observed that there was a decrease in dose as well as dose volume metrics with the new heart for all survivor groups, regardless of their primary cancer diagnosis. And the largest change were observed for Hodgkin lymphoma survivors and CNS tumor survivors, owing to their higher prescribed dose as well as the types of fields and blockings used for these patients' treatment. When we explored the impact on cumulative incidence estimates, broadly the results were consistent with previous studies. As you can see, we found that relative risk increased when mean heart dose was above 10 gray, but there were some significant increases in risk in the moderate dose range categories. So on this plot of cumulative incidence with respect to time, the solid lines represent cumulative incidence estimates based on the new heart dosimetry, whereas the dotted lines represent cumulative incidence based on the old heart dosimetry. You can clearly see there's a significant jump or significant increase in risk in certain moderate dose range categories. Finally, when we assess the changes in dose response relationship, we found that slopes based on new dosimetry, slopes of the dose response relationship based on new dosimetry were much steeper. In this plot, you have relative rates or relative risk on y-axis. On the x-axis, you have mean cardiac dose. The black circles represent risk based on old dosimetry, blue squares represent risk based on new dosimetry, and the lines represent dose response model, respective dose response model. And you can clearly see the dose response relationship based on the hybrid model or new model are steeper, which correspond to higher risk at lower doses. And additional analysis and findings based on the dose volume metrics are also outlined in detail in our most recent publication in Green Journal. We again are very thankful to both the collaborators as well as reviewers because their suggestions were great and they brought out the best out of our work as well as manuscript. Since completing the second aim where we studied the impact, we've been focused on cardiac substructure level studies and have presented the most recent results in national and international meetings like American Society of Clinical Oncology, American Society of Radiation Oncology, AAPM, ESTRO, and so on and so forth. As an example, we've already shown while the whole heart can handle radiation up to 10 gray without elevated risk of coronary artery disease, individual arteries cannot. If we can, we should try and keep the radiation to right coronary artery and left anterior descending artery below 5 gray, whereas the other arteries seem to be able to handle radiation up to 10 gray. And we've completed multiple complex analysis based on substructures in order to find tolerances of key substructures. And we're planning on submitting this publication next month. For the next step, we have a new concept proposal which has been approved by both CCSS cohort as well as St. Jude Lifetime cohort. With this proposal, we now have access to the data for modeling, and our statistical team gets dedicated time and funding for the next part of the analysis. This new concept proposal has two specific aims. One is to develop and validate the risk prediction model, which is the final part of my PhD project. And the next part is to integrate these developed models into treatment planning systems and then establish their use via a in silico study in contemporary cohort of patient. Now, we plan to develop the models using St. Jude Lifetime cohort as training data set and CCSS cohort as the validation data set. This design basically allows us to maximally leverage the strength of both of these cohorts. Specifically, the clinically assessed cardiovascular disease outcomes for St. Jude Lifetime provides us with the accuracy needed for the model training, whereas the large sample size of CCSS cohort provides us with the effective validation sample. This slide summarizes grade 3 to 5 cardiovascular disease outcomes for both the cohorts. To demonstrate the feasibility, we actually conducted a proof of concept modeling study for heart valve disease, which, as you can see, is the least prevalent disease in both St. Jude Lifetime cohort as well as CCSS cohort. What we found was when we added the heart valve dose, the substructure dose to the prediction model, the predictive power increased beyond what was observed when we only used mean whole heart dose. And this was consistent for both St. Jude Lifetime cohort as well as CCSS cohort. We've already completed dosimetry on cardiac substructure level for both cohorts. That amounts to about 15,000 individuals and nearly 280,000 unique dose and dose volume metrics. This slide summarizes the development process. We plan on using piecewise exponential model to examine the relationship between the outcomes and predictors, and our primary focus will be on prediction performance. Regression coefficient of the final models will be converted into integer scores for ease of use. Then we will use the regular statistical tools like area under the curve and concordance statistics to evaluate the performance of our models. We plan on collapsing the risk scores into different risk classification group. And as explained before, the external model validation will be carried out in CCSS data. This is an example table illustrating risk classification. We plan on collapsing the risk scores into different risk classification group, predictive of low, moderate, high, and very high risk for each of the cardiovascular disease outcomes that we study. You can see that we have two models listed here, the substructure model and dose volume model. Substructure model is the most complex model that includes dose volume metrics, and substructure dose as covariates, whereas the dose volume model has one less layer of complexity that only includes whole heart dose and dose volume metrics, but does not include substructure dose. This is just an illustrative plot of how the cumulative incidence plots might look like for dose volume model and substructure dose model. This is just an example plot. This is not a real data. Now, after we're done developing and validating the risk prediction model, we will implement the risk calculators within treatment planning system through a scripted graphical user interface, or GUI. Within the TPS, user will be able to select the treatment plans of interest. So right here, you can click and select the treatment plan for the patient, and the script or code will auto-populate all of the dosimetry values like mean dose to the heart, V20, V5, mean dose to relevant substructures. And the risk calculator will also allow the user to manually enter and modify patient's age, sex, chemotherapy exposure, doses, etc. Then the script will calculate the personalized predicted cardiovascular disease risk for the patient's treated plan based on the actual treatment exposures and demographic variables, and then finally create a report. Now, to demonstrate the first use of risk calculators within treatment planning system, we have planned an in silico study with about 30 Hodgkin lymphoma patient from MD Anderson. The IRB protocol for this study is under Dr. Howell. After finishing the integration of risk calculators, we will determine the predicted risk at the time of treatment for these 30 patients to show, okay, this is how you use this. Now, nowadays, we can develop multiple different treatment plans for the same patient that meets all the clinical requirements. With our validated risk prediction model, we can take it one step further and prospectively predict which one of the acceptable plans has the least possible risk. In this manner, we can rank and choose the clinical plan that confers the lowest risk. We then stratify the patient into different risk categories based on the radiation level. This will help us design an individualized follow-up plan, which is essential for early intervention and for maintaining a good quality of life. These are my acknowledgements. I'm very thankful for my PhD advisory committee, my advisor, all the external advisors and collaborators, my lab partners, and I'm very thankful for the funding that I received, which partially or fully funded my research over the past few years. Thank you. I will now let Constance take over.
All right, so now I'll talk about dosimetry for radiotherapy-related subsequent colorectal cancer studies. So the motivation for my PhD project, which is the focus of today's talk, is that it's been 9 years since Henderson et al. Reported risk and associated risk factors for gastrointestinal SMNs in the childhood cancer survivor study. The study at the time included 24 colorectal SMNs. However, since the study, 47 additional colorectal SMNs have occurred in the original and expanded CCSS cohorts. They also use prescribed radiation dose to the abdomen and pelvis as a surrogate for colorectal dose. So for my PhD project, what we really wanted to do was update this report by Henderson et al. By including the 47 additional colorectal SMNs. And we also wanted to update our dosimetry by including colorectal specific radiation doses in our risk factor analysis. So on the right, it shows the concept, the CCSS concept proposal that my PhD project is a part of. And the table shows the many collaborators that I'm working with on this project. If you want to see a detailed report of this concept proposal, it's provided in that link. And it'll also give information on how we're including other factors in addition to radiation therapy, such as, patient age or sex, or even chemotherapies that they may have received for their cancer treatment. So childhood cancer survivors who received RT have an increased risk of developing colorectal SMNs. Most colorectal SMN risk studies in childhood cancer survivors have not included colorectal specific RT dose data, but rather have included less specific RT data in their risk factor analyses, such as including categorical classification, so whether the childhood cancer survivor received RT or not for their primary cancer management, SMN proximity categories, so whether the SMN occurred in beam, near beam, or out of beam, prescribed dose to the abdomen or pelvis, or dose to the site of the SMN. So studies using these data have helped us to understand the relationship between RT dose and colorectal SMNs, showing that colorectal SMNs are associated with abdominal RT, increase with direct abdominal pelvic RT, are more likely to develop in near beam, increase with mixed modality treatment, and increase with RT dose to the site, increased RT dose to the site of the SMN. However, colorectal dose volume distribution and irradiated volume have been largely unexplored for colorectal SMN risk studies. So a primary reason for the lack of studies evaluating colorectal specific RT data is the lack of a validated method for estimating these dosimetric data. To assess the relationship between RT and colorectal SMNs, follow-up data must be collected for decades after treatment. And hence, childhood cancer survivor studies typically include individuals treated in the pre-CT era of radiation therapy, and so their doses must be reconstructed since we don't have CT data of the patient's anatomy at the time of their treatment. So the RT dose reconstruction method used by the MD Anderson late effects group involves analytical model calculations combined with an age-adjustable computational phantom, which is shown in the figure on the right. It's been used in over 120 late effects studies, and it's also been used for over 20,000 patient reconstructions. Currently, it has 20 organs, but it does not have a colon or rectum organ model. And so that's where the first part of my PhD project comes in, to develop, validate, and integrate into our age-scalable computational phantom an average colorectal model that incorporates anatomical variations of pediatric patients. So this shows the scope of my PhD project, where aim 1 is the development of the anatomical colorectal model, and then aim 2 is to develop dose response models and to do a sensitivity analysis of the dose response model. For today, I'll just focus on aim 1, the development of the model. So for this study, we acquired 114 non-contrast whole body CT scans under an IRB protocol. These are pediatric patients with medulloblastoma, age range of 2.1 to 21.6 years. 74 of the cases are male and 40 of the cases are female. Then to ensure contouring consistency between the different cases, I developed contouring instructions using RTOG guidelines, and then my instructions were reviewed by a radiation oncologist. And then Dr. Arnold Paulino, a pediatric specialist, reviewed 20% of the contours. And I actually have manually contoured all 114 colorectums. And then Dr. Ethan Lumiere, a GI specialist, reviewed 100% of the contours. So here describes how we developed our colorectal model. So first we choose an anatomical template from the 114 cases that we have. And then we spatially normalize all the contours using median colorectal length. So if you look at before normalization, you can see that the blue contour is much shorter in length than the other two. And this makes sense because if you look at the table, you can see that the blue colorectal contour is for that of a 3.2-year-old, whereas the other two are of a 12.5 and a 21.6-year-old. But since we already have age-scaling functions in our phantom, we're really more interested in seeing the shape differences. So we normalize them all to the same length. So after normalization, you can see the shape differences better between the different colorectal contours. And then we registered all the contours to the anatomical template using a deformable registration method, specifically the constraint symmetric thin plate spline robust point matching method. So this video here just shows a registration between the template and a patient case from our data set. And then lastly, the deformed contours are used to generate a PCA, or principal component analysis based statistical shape model of the colon and rectum to extract the dominant deformation modes of the population. So this video shows each of the deformation modes that were identified by the PCA. And conceptually, what the video is showing is the anatomical differences across the population from the mean population shape that have the most variance to the least variance. And this gives us insight as to just how similar or dissimilar the colon and rectum are between patients. So I just described our model development stage, and we actually did 3 different tests at the beginning, where first we did an age and sex neutral model, where the model was trained on all male and female cases, as well as all cases as well as all the cases of different ages. And then we did a sex-based model where we created one model that was trained just on the male cases and a female model which was trained just on the female cases. And then we did an age-based model where we split our data into 3 different age categories and developed and trained models based on each of these age categories. However, after we looked at the data, we decided to just stick with the age and sex neutral model. So that's the results I'm going to be presenting today. So first we'll do a geometric evaluation. So the figure here shows a static representation of the video we just saw. This figure shows just the first 3 deformation modes that were identified by the PCA. And what you're seeing is the geometric variation along each deformation mode, which is defined as the population average colorectal model, which is shown in the center column. The center column is the average model, plus 1 standard deviation, which is shown on the right column, and minus 1 standard deviation, which is shown in the left column. The color map shows the deformation magnitudes, with shades of red showing larger deformations and shades of blue showing smaller deformations. And here you can see that each mode is associated with a different way in which the colon and rectums are changing. So think of each mode as a shape changer. And what I mean by that is, for example, in mode 1, which is shown in row 1, if we change the mean shape by subtracting 1 standard deviation, which is shown in the top left subplot, we see that what is changing the most with mode 1 is the orientation of the ascending and transverse colons. Then in mode 2, shown in row 2, this is related to the location of the inferior border of the ascending colon, which starts more superiorly in the patient when we subtract 1 standard deviation along mode 2, and starts more inferiorly in the patient, getting closer to the sigmoid colon when we add 1 standard deviation along mode 2. So the figure on the right shows the number of PCA modes on the x-axis and the explained variance accumulated on the y-axis. So when the PCA identifies the different deformation modes, it also calculates the amount of variance that's explained by each mode. So if you look at the x-axis and you look for how much variance is explained by the first mode, you'll see by the red dot, it explains 45% of interpatient variation in our training data set. And then when you accumulate that with mode 2, that explains about 62% of the interpatient variance. And then with mode 3, the first 3 modes describe about 72-73% of the interpatient variation. So just the first 3 modes, you're already almost getting about 75% of the interpatient variance that's explained. And when you look at 95% variance, that's explained by 14 of the principal component analysis modes. So then we looked to see how well our model generalizes to unseen shapes, or how it can represent unseen shapes. So we computed the dissimilarity coefficient and the Hausdorff distance. And so what the dissimilarity coefficient is when you compare 2 contours, so say A and B are 2 different contours. In this case, they don't have any overlap, so our dice value would be 0. And then as they get perfect agreement, perfect overlap, our dice value would be 1. So this is looking at an overlap between 2 different contours. Hausdorff distance, what this looks at is it's looking for the maximum distance between the boundaries of the 2 different contours. So right here. And so this is better at looking at sort of your local deviations or spikes in your contours. Up here is showing the dice values, where the x-axis is the number of PCA modes, the y-axis shows the dice values. And something that I should explain for PCA models is that you can either reconstruct shapes based on all the modes that were identified, which in this case was 103, or you can reconstruct using a subset of the modes, say 20 or 30. So if we reconstructed the test shapes of a patient using just 20 or 30 of the modes, you can see that our average dice value between the model reconstructed shape and the patient shape is about 0.75, 0.8. And then as you increase the number of modes, when you reconstruct the shapes, your dice value improves to an average of 0.89 when you include all the modes. And then for Hausdorff distance, since it's looking at that largest distance between the contours, lower values are indicate better agreement between your shapes. So you can see that as you include more modes, your value decreases. You have better agreement between the boundaries, and at 103 modes, the average Hausdorff distance is 8.6 millimeters. To visually show the difference between reconstructing our model with all modes versus a subset of modes is shown on the left. The PCA reconstructed surface over here is reconstructed with all 103 modes. And when you compare that to the patient-specific shape, which is shown in blue, you get a dice value of about 0.9. And then over here, you can see that the PCA model is reconstructed with 14 modes. And when you compare that with the patient colorectal surface, you get a dice value that's a little bit lower of 0.76. So we'll move to the dosimetric evaluation. So we chose to do a Wilms tumor study because it's a common cancer in the CCSS and because the colon is in-field or partially in-field for these cases. Parameters were based on historical treatment records of 318 individuals from the CCSS. Treatment plan parameters were 3D conformal RT, prescribed dose of 20 gray, 10 fractions, 2 gray per fraction. Modality is photons and energy is 6 MV. So here the figures are showing, over here showing a right-sided flake field. And since this is from the patient's point of view. This is the patient's right side. So that's why this is the right sided flank field. And then the other one is showing the left sided flank field. And so we place the superior border at T9, inferior border. Inferior border is placed at L5, inferior border. The left border is placed at T12, left border for the right flank field, and at left external body for the left flank field. Right border is at right external body for right flank field, and at T12 right border for left flank field. Just to show you kind of how different patients' colon can lay with respect to the field borders. Over on the left side are showing the right sided flank fields, and you can see with this patient, parts of the ascending and transverse colon are in field, but then also you have parts of the ascending colon near field. Whereas for this patient's case, you could see that pretty much the entire ascending colon is in field. For the left sided flank fields, you can see that for this patient, where my laser pointer is, the transverse, the descending colons are both partially in field. But then up here for this patient, while the transverse is also partially in field, pretty much the whole descending colon is in field, and even maybe parts of the sigmoid colon are in field. So that's just a good visual. So earlier I explained how we can use the PCA model to reconstruct shapes either on using all the modes or a subset of modes. And should we include all these modes in our final model that we're going to include in our phantom? And if, should we include them, and then why wouldn't we include all of them? So here I put the word eigenmode, but you'll often see interchangeably the word eigenmode, mode, deformation mode, or conceptually even shape changer. So earlier I showed these deformations, which are mode 1, 2, and 3, but here's just showing the mean shape plus 1 standard deviation along each of those modes. And then down here, I'm showing modes 30, 60, and 103. And what I kind of wanted to point out here is that these modes that are, these modes 30, 60, and 103, when you look at them and see how much variance they explain, right? So for example, 60, accumulated, it's starting to get to 100%, but the amount of variance that that specific mode explains is only a fraction of a percent. So it doesn't really explain much variation in the patient population. And also, although these color maps are showing some regions of red, I should point out that the color maps are all scaled differently. So the magnitude for red here is 2.2 for mode 30, and then the magnitude for red is 29 for mode 1. So these modes, you can already see their magnitudes are much smaller, and then when you just look at them visually compared to the mean shape over here, they're not changing much. And then also when we look at this figure, the amount of variance they explain is not much. And so because some of the deformation modes that explain lesser interpatient variance, some of these may actually be more attributed to noise. And so we wouldn't really want to include those in our final colorectal model. So here we're looking at the change in dose versus the number of included modes, where the number of included modes is shown on the x-axis, and on the y-axis is showing the absolute change. So the absolute change is the dose computed to the patient-specific colorectum minus the dose computed to the PCA reconstructed colorectum for the given number of eigenmodes, along the x-axis. So, and then V5 is the first plot, is showing the volume metrics, where V5 is the volume receiving dose greater than or equal to 5 gray. And if you look at it, you can see that as we include more modes, we see, the absolute change kind of bounces around. But then as we include more and more modes, it starts to plateau and stabilize. And for this patient case, the absolute difference is kind of, close to 0. So that's good. And then if we look at the dose metrics, D1, D50, D95, mean and max, where D1 is the minimum dose received by 1% of the colorectal volume, you can see that for this specific patient, the absolute change is pretty much 0 for all these metrics when we're comparing the patient dose to the colorectal model dose. And here I was just trying to show, as we include more modes, we saw earlier that the DICE values improve, right? So 76, 87, 90. And then we're also seeing that as for at least the volume metrics, we see that the absolute changes kind of bounces around when we only include a smaller subset of modes. And then as we include say 50 or 60 or more, the absolute change is about 0. So this table is showing the absolute difference between the patient-specific and the model-derived dosimetric data, which we just saw, but it's only showing it for when we create our model on all 103 modes. We did this for each of the 10 test patients, but here I'm just showing the mean value of absolute difference for the different metrics. So here for V5, you can see that the mean absolute difference is 0.62. And then for the mean value, say the absolute difference mean value for that is 0.2 gray. So our model is able to geometrically reconstruct shapes. And then when we compute the dose, it's pretty close to the dose that we see in our colorectal model. So today I described pretty much this whole model development stage. And now we're currently wrapping up the model integration, where we're going to put it into our Phantom and then integrate it with our age-based scaling functions. Then we're going to match the model to ICRP 89 reference data, where we match the length and the mass of the colon by different ages that were reported in the ICRP 89 reference report. And then we also want to include substructures to the model. Similar to what Suman's done, we want to include substructure doses to our risk and risk factor analysis studies for colorectal SMN in childhood cancer survivors. So acknowledgements and references, and thank you.
Great, thanks so much. Those talks were fabulous. And we have lots of questions in the chat as my camera slowly comes up working. If everyone wants to turn their cameras on, we can have a nice discussion for the last 7-ish minutes. So let me get my screen organized. All right, so starting out, I think a lot of these questions will apply to all of you, so feel free anyone to jump in. First, we have Marianne Asnar, who says, thanks for a great talk. It is concerning that the risk is higher than expected at low doses. What has been the reaction from clinicians? Has this sparked an interest in contour substructures, I'm assuming in the clinic, more regularly?
Yeah, so Marianne, I love that question. It sort of remains to be seen. I think at least at MD Anderson, there's a heightened awareness, and I know that our lymphoma team regularly contours substructures and really drives that dose down. But I don't know that that's universally true. The paper's not published yet. The substructure dose response, James Bates is actually the first author of that, and he presented sort of a combination model at or the individual substructure models at ASCO, but that's not really a radiation oncology community. And then we presented the cardiac disease data at AAPM, but again, not the group that's going to be contouring. And at Astro, we sort of provided, and I think somebody else Amit asked about combined models, right? And so we looked at like which substructures were the most predictive, and James presented that at Astro. And so I unfortunately wasn't able to attend. We're still on travel restrictions, but it did seem that there is a lot of interest in this, and so I do hope that it's going to, become more common. Especially, we're expecting to submit the paper January of next year. And so I think when that's published, I'm hoping for almost like this paradigm shift of, yes, we're going to start doing this. And then really, once we develop that prediction model and script it into treatment planning systems, then you could actually look at different plans and identify which ones were the highest risk, right? Live, real time. And even use it to guide some of our survivorship counseling.
I think if you have any chance to document the impact and somehow capture, I don't know with survey, but the changes of attitudes that come from all this research, that would be wonderfully powerful. But I understand that there's only so much you can do.
Yeah, if the NCI decides to fund me, we'll do a big scale, and without funding, we've sort of defined a scope. So Suman just had his concept approved. It's actually with the CCSS and the St. Jude Life. So there is a huge subset of the work that's going to happen no matter what.
That's great. Thank you.
Awesome, thank you. So we also have a couple of questions that relate to the generalizability of these models that you guys are identifying. So Georgios Intentas asks if the dose constraints that are derived from these pediatric cohort studies that you're doing applicable to adult populations, or if we need different specific dose constraints for each of those two populations. And then similarly, Jelka Knježević asked if the dose response models that you're identifying are only applicable to conventional RT, if they're also applicable to proton.
Yeah.
Who wants to tackle that?
I want to tackle it because it's so key, right? So I think, you know, in James Bates's 2019 paper, he looked at age response and did not see a huge differential between the lower age groups. You know, the CCSS actually has survivors that go up to age 21 at diagnosis. And so at least in young adolescents or young adults, we didn't. And so, you know, at the end of the day, pediatric models are very conservative, probably compared to adult models. So, you know, as a clinical physicist, I would probably take a look, and, you know, you can still use it as a comparative metric when you're looking at individual plans. And then with respect to generalizability to protons, I think absolutely yes, right? Because it's really dose, right? So we're looking at physical dose. And so particularly for Hodgkin lymphoma patients, George Nietes, who's on the call today, just published that great paper in the Red Journal where they looked at Hodgkin lymphoma patients, and you know, you can't always get the substructure doses low. So we're not really talking necessarily about out of field dose. When we're treatment planning and constraining, we're talking about partially in beam organs. And so we're talking about the proton dose, right? And so I think yes. And I think importantly, you know, in situations where you have patients who may not be approved for proton therapy, this could be an argument where you say, look, I can demonstrate that in this adolescent, right? Because often 18-year-olds fall into a different classification for insurance, right? And so you could say this young adolescent would really benefit from proton therapy in this scenario. So I think yes, and that's why our intention is to script it into commercial treatment planning systems so that it can be readily used. And I think Suman, you want to say anything additional in terms of your thoughts on that?
I think you basically covered everything, Dr. Howell.
Sorry.
No, you're good.
Awesome, thanks. So another kind of common theme had to do with uncertainties. So Mark Little asked, I was interested in the use of substructure dose. Presumably a big problem with substructure dose is the larger uncertainties because of the smaller size of the targets, heart movement, etc. Was this taken into account in any of your analyses?
So Suman, why don't you talk about the geometric analysis that we did in your 2020 paper?
So in terms of analysis for uncertainties based on geometry, we validated our heart models in two ways. One was anatomical validation and one was the dosimetric validation. We calculated the dissimilarity coefficients as the heart, as the patient aged, and we compared the anatomical accuracy with age-matched phantoms from MD Anderson as well as NCI, and we found that the dissimilarity coefficients for even substructures were comparable to inter-observer variability. The overlap coefficients were more than 60% for even the substructures that we studied, which suggested that we could use substructure for mean substructure dose calculations.
Yeah, and so I think that's exactly, you know, and Mark, keep in mind, there is inherent uncertainty in late effect studies because we're reconstructing the doses. But one thing that we often do is we look at sort of dose categories. So we look at ranges of, you know, less than 1 to 5 and 5 to 10 and 10 to 20. So there is uncertainty, and it certainly varies individually, patient by patient. But, you know, I think at present, these retrospective cohorts are the only ones we have outcomes for. So yes, there is higher uncertainty. I'm going to guess it's 10 to 20% in substructure dosimetry. You know, we have not yet done that analysis. It's, you know, planned, but we did look at the geometric uncertainty, and what we found is it was quite comparable, you know, using different models was comparable to that inter-observer contouring. So if one person contours it, another person contours it on the exact same patient, you have uncertainty in the position of it, right? And so we didn't find that it was worse than that.
Yes, I mean, presumably though, I mean, you're just talking about a single image. What I was also getting at was the heart movement, which, I mean, that presumably, well, unless you had a whole series of CT slices, images, you wouldn't be able to really assess. But
no, not yet, right? So this is a first step, right?
Yeah, sure.
So
yeah, sure. Yeah.
But ultimately, we would like to get there. I mean, this is an interest of our group, and so we've incrementally been enhancing the methodology. Every project moves it a little bit forward. So it's on our to-do list.
It looks like you've made tons of gains in even just the past few years. And I do want to be sensitive to everyone's time. We are now over time. Sorry to cut off this vibrant discussion, but thank you all so much for coming. I'm sorry that we didn't get to everyone's questions. I've recorded them all. I will give them to our speakers. So if they want to reach out and answer some of those lingering questions, and they can. Also, any trainees or ECIs, please be sure to hop into our other meeting room for our small group roundtable discussion that will be starting in just over 10 minutes. So I put the link in the chat. I'll do it again. Hope to see you guys there. Thank you so much. This was wonderful. I hope you all enjoyed it as much as I did, and have a wonderful rest of your days or nights.
Bye-bye.
Thank you.
Thank you. Great set of talks.